El día de hoy vamos a tener una conferencia que va a estar a cargo de la doctora Evelyne Loyer. La doctora Loyer es profesora de radiología abdominal del hospital MD Anderson de Houston. La doctora es experta en el área de tumores hepáticos. Tengo el gusto de conocer a la doctora a través de un amigo, un cirujano hepático muy famoso, el doctor Nicolás Botey, que me dijo que me recomendaba a una de las mejores radiólogas en tumores hepáticos para que compartiera con nosotros, y es para nosotros un privilegio tenerla aquí explicándonos acerca del diagnóstico de los tumores hepáticos. Para los que acaban de entrar, la clase de la doctora Loyer va a ser en inglés, pero tenemos una traducción simultánea. Tenemos de intérprete a la doctora Gladys Argüello, que es compañera radióloga nicaragüense que salió de acá, pero ella se encuentra haciendo un fellow en Estados Unidos, en Colorado. Está haciendo un fellow ahorita de radiología cardiotorácica, y ella está haciendo el pathway, que tiene que hacer 4 fellows para tener la licencia de radiólogo en Estados Unidos, y estamos muy contentos por la oportunidad que tiene la doctora y porque esté con nosotros ayudándonos en la traducción. Habiendo dicho esto, los dejo con la presentación de la doctora Loyer. Bienvenida, doctora. Welcome. It's
Thank
a pleasure
you.
for us.
No, thank you.
I hope you
not,
understand what I say, but
I did, and I wish I did not, because the qualificative probably do not apply, but that's okay. I'll do as if I did not understand anything. Okay.
Okay. Thank you.
So I have go ahead.
Todo el mundo, vamos a cerrar los micrófonos para que pueda hablar tranquilamente la doctora. Muchas gracias. Okay, continue, doctor.
So it's very dense. I have packed a lot in that talk, and I will try to slow because I think translating is not simple, and I might jump over a few slides because of time constraint. Okay, but if there is any major question that comes up, please you can interrupt me, and I might use the chat a little bit to ask you a few questions. So basically what I'm trying to do here is to give you a frame. So the basic way that I have used to look at diagnostic tumors, and hopefully this can give you an area, a way of
Hago el abordaje de los tumores.
deal with hepatic tumors. So Gladys, is this a speed that is good or is it too fast? Can't hear you. Yes, it's okay?
It's okay. It's okay. Continue.
Okay. Okay, so before we go ahead and talk about the subject, I want to talk a little bit about technique. So when you have a patient who comes with a hepatic tumor, the question that we have is which modality to use. And for liver imaging, we can use ultrasound, we can use CT, we can use MR. I did not list ultrasound on my slide because we don't use it, but I want to say this is an excellent modality, obviously, and especially with the use of contrast material, this is a great technique. We don't use it because we have all of that. I will talk about
tomografía y resonancia, y con el contraste podemos delimitar la lesión perfectamente.
Because that's where I know what I'm talking about. On MR, I don't know too much. But there are other reasons why I want to talk about CT, and you will see as I go on this talk. So if you have a patient who shows up with the diagnosis of hepatic tumors, which modality would you use? If you can put in the chat, just put CT or MR, just to get an idea of what your practice may be.
We mostly use CT here.
Okay, good. So what I want to say is that the answer I would get in the US is probably MR, because every time you talk about imaging the liver, immediately the reaction is MR. And I think this is true and this is not true. It is true because MR, technically, we all know that in a vacuum is a better technique because we have many types of sequences that we can use to assess the nature of the tissue, because this contrast resolution is superior to that of CT, and because there are liver-specific agents. But in real life, on a daily practice, the answer is not so clear. There are situations where, many situations actually, where CT might be better for the patient, and we have to have patients who are able to cooperate for MR. So the choice of the modality to me is not that straightforward, and I think CT remains the #1 modality to be used. Now, when we talk about CT, the same way when we talk about MR, the big question is, what are we talking about? What quality of images are we talking about? Because if we say I had a CT, I had an MR, that doesn't tell me how good the images were, and that's the key question. So here, there's an example of what I'm talking about. This paper was done to look at dose, to see what is the dose received by patient in really routine examinations in 4 different places, 4 different hospitals. If we look at multiphasic studies, which is what we do for the liver, the patient that do get a CT at the site #1 received a dose of 24 millisieverts. But the patient who has a CT at site #3 received a dose of 45 millisieverts. So evidently, those are not the same studies, right? This one is going to be grainy, low dose. The sensitivity will be low. This one will be better. But in the literature, quite often, you don't have those details. It's getting better, but it's not always been the case. An illustration of the problem is this one. Those 2 papers, one in radiology, one in the Journal of Magnetic Resonance Imaging, were published 12 years ago. And these papers were meta-analysis looking at the diagnostic performance of CT versus MR in the detection of colorectal liver metastasis. The conclusion of those papers was that MR is better. And clearly, that's the conclusion, and that's where people stop generally. But when you dig a little bit, when you look at the material and methods, when you look at the results, you realize that the publications that were used to do this meta-analysis were of very variable quality. And surprisingly, considering that the subject is the diagnostic performance of 2 techniques, the technical parameters were not part of the inclusion criteria. The size of the lesion detected were not part of the inclusion criteria, and the gold standard, which is really important because that's the only way we know that something we see on imaging is seen on pathology, was not great for all papers. So there were many publications here that had a very poor quality and poor value, and the conclusion of those publications was mediocre, could not be trusted. So we looked at that and we removed all the publications we felt should not have been included. And we ended up with the same result, that MR was better than CT, but that the difference between the 2 techniques is very small. So in the majority of the cases, there is no difference. There are situations where there is a difference. So all I want to say is that if you have the choice between the 2, the belief that MR is the solution for everything in the liver is not correct. I think they are very complementary, and I think CT has been undermined and should remain the dominant modality that we use.
Pero siempre seguimos, ya tiene que ser la modalidad.
Is the issue of radiation, because every time you read a paper about MR, CT, there's always this idea that, oh yeah, CT, but there is a risk of radiation because there is morbidity due to the ionizing radiation. Now, in adult population, and I don't know the situation in Nicaragua, but in the US, it's crazy. So in adult population, there is absolutely no data to show that in an adult population, and a fortiori a population of patients treated for cancer, the dose that we use for diagnostic imaging has any morbidity. There is no evidence of that. We have used high dose for many, many years without any patient that we can pinpoint to say this patient had complication because of too many CTs. So we try to look at that objectively, not just subjectively, and we reviewed patients who had metastatic colon carcinoma, were treated surgically. So people who had expected survival longer than most patients with colorectal metastasis, and we had 28% survival at 10 years. So we look at this patient and we look for second malignancy, and what we found is that only 18 patients developed second malignancies, and that the type of tumor they developed was not some tumor that you would say for sure this is radiation induced. In addition, when we
una lesión que claramente era causada por radiación.
People who had not had any exposure to imaging or very little. In this group, there were 35 malignancy diagnosed during the same time. So we have no evidence, and we should not reduce the dose or be careful. At least we have to be careful, but we have to be very cognizant that what matters is the quality of the images. If the CT is indicated, then it should be done well without being worried about radiation. And of course, there's been submitted many times because it goes against the flow and we have trouble having it published. So really, the conclusion of those few slides is that the technical superiority of MR over CT is overstated, that there are situations where MR is absolutely needed and superior to CT, but majority of the time CT is great. The choice we make is based on the clinical question, right? What is the question we want to answer? The local expertise. If you are very good at CT, do CT. If you are very good at MR, do MR. And then the patient cooperation. Some patients have trouble cooperating for a long examination when CT is very quick and it's easier on patients who are in pain or have trouble with their breath. Radiation, I just mentioned that. And then the point that I want to make also, especially for the trainees, is that you need to read the material and methods and the results, and don't believe the conclusion of the bad, because the literature is very uneven in its quality. And we are pushed at publishing as much as we can, and the end result is problematic. So is the translation doing okay?
Just a little bit, go a little bit slow, please, because
Yeah.
Dr. Arguella, she needs to hear you and then she needs to translate. You know,
I know, I could not do what she's doing.
yes. So,
Okay, I'm going to slow down.
Just you can finish your what you say and then give just a second
Give
to
her a break.
continue so
Okay.
she can have time to translate. Sorry.
Yeah. Okay, I feel like I'm at the United Nations, right? That they have professional people translating at a big speed.
Yeah.
Okay. Okay, so the next part is the diagnostic, right? So what we have to do as radiologists is to detect and to characterize. The detection depends on the conspicuity. The conspicuity depends on the size and on the difference in attenuation between the tumor and the background. And that is completely dependent on the technique, on the quality of the images that we're going to have. The other part is our brain. How, what do we do if we have very good technique? Are we taking advantage of it and taking the time needed to look at the images and not read too fast? So the technical factor, we have the resolution. We need a very good spatial resolution and a very good contrast resolution. We need to optimize that. We can optimize the contrast or improving the contrast by using IV. The IV, you need to inject 4 to 5 cc per second if possible. The iodine content needs to be high. We use Omnipex 320. And then the last thing that I will talk a little bit about is the non-contrast, the importance of the non-contrast in the detection of small lesions. And most of it for this is matter for the small lesion, right? A lot of what I'm going to say now is if the tumor is 1/1 centimeter or 2 centimeters, we don't have any issue about detection. So we use a multiphasic technique for evaluating the liver, and the multiphasic technique means 4 phases: non-contrast, late arterial phase about 35 seconds delayed, a portal phase about 70, and a delayed phase, ideally 5 minutes. So just a few examples. These are images that belong to the same patient. On the left, you can see the vessel very well, and you can see some nodules, which are metastases. This patient had colon carcinoma. And on the right, we don't see very much, right? The vessels are barely visible, the mets are not seen, and yet this is done a week apart. And the reason is this image is poor. The contrast is very poor. Just to show you that this is the same patient, you can see that the metastases are visible on the arterial phase, and on the other images on the arterial phase, we see them very well, but the non-contrast was very poor. Another example of difference in technique, same patient, I think it's about a month apart. You can see the parameters are not the same. This is a poor bolus, this is grainy, this is better. So when we talk about CT, that's the minimum, that's what we want. This is not good enough. So for this one, I'm going to talk about the injection. This patient has neuroendocrine tumor metastatic to the liver. There is a dominant mass that you can see on all 3 images. Each image belongs to a different study. Same patient, but 3 different dates. You can see that there are small metastases in segment 8. But you don't see it on this one. And you see them, but not that great on this study. And the difference between the 3 studies is not the disease. The disease has not changed, it's the technique. This was a much better bolus than here. So the sensitivity will change depending on the quality of the images, including the injection rate and the timing of the images. Sorry. Now I want to show you a few cases where the non-contrast is important. This is a CT done on a patient who has breast carcinoma, and this is a staging study. You can see here that, first of all, the technique is not very good. It's kind of gray. It's so plain too late. We see maybe something here. This is now the portal phase. So on the portal phase, you can see that there is a met right here that I don't see on this phase, which is the later phase, which is usual and frequent with adenocarcinoma. But look at the pre. So this is the non-contrast of this patient on the same date. And you can see that the only phase that gives me an idea of the extent of disease is this series. So this is very important for some of these tumors to have a non-contrast scan. This is another patient, also a breast CA patient. If you look at this phase, this is the portal phase. This is a very good study. It is not grainy, the vessels are sharp, the cyst is very dark, the margin of the cyst are very sharp. So I'm happy with that, and I don't see anything. But if I look at the pre on the same day, there is a met right here, which we don't see. So even a very good portal phase, a very good technique, because the tumor enhances quite fast and become isodense to the background, we are missing it. Another example that is a little bit more tricky. This patient has, this is a pre-op study. The patient has metastasis in the left side of the liver, and this is pre-op. The right lobe, we say no disease. This is 4 months later after the surgery. And you can see that there is a big metastasis. So if you go back to the pre-op study and you look at the pre, on the pre, there is a calcification. Probably here. So what this case shows is that on pre-op studies, we need a good pre, especially for tumor that may calcify, but in any case, a non-contrast study is very important. So the liver protocol includes the non-contrast, but a non-contrast needs to be of high quality, not a lower dose and everything else. And this case is a case I saw just recently. This was read as too small to characterize, non-specific, cannot exclude a MET. But on the same day, if you look on the pre, clearly there is a hypoattenuating nodule right here in the same location, and this is bigger. So this is a MET, or this is a hemangioma. But we cannot call it hemangioma. Patient has colon CA, so, and has already liver met, so this is a MET. But we don't need to say too small to characterize. We can often characterize if we use the pre or the delayed, but in this case, the pre. So for the detection, the point is to look at the technique. Make sure that you're happy with the images, otherwise it has to be repeated. Don't forget to use the non-contrast. And then there's something that can be done to help the read, to go back once you are done and you have, especially if you see nothing in the liver, go back and look specifically at the portal vein, the hepatic veins, the biliary tree, and the arteries. So when you do that, you might pick up small lesions abutting these structures, or you are going to be able to recognize anatomic variant, or you are going to be able to see small thrombi that you'd have missed otherwise. The other thing to do systematically, particularly in the post-op setting, is to look at the sagittal and coronal reconstruction and to scrutinize the diaphragmatic surface, the undersurface of the liver. Super important, because lesions that are going to be there on the axial plane with partial volume, you might miss them. Okay, and of course, what is our state of mind when we work? That is the problem. So now I'm going to talk about characterization. And when we characterize a tumor, we usually are in one of three situations. This is definitely benign, definitely malignant, or we don't know.
Roberto.
¿Sí?
Roberto.
It's okay?
Yes.
So I'm going to talk of both definitely benign and definitely malignant, and we're going to start with the definitely benign. So those are tumors that we can recognize because of their patterns. It's a pattern recognition. We don't really need to analyze that much. This is the list of what we see frequently. The diagnosis is usually made or often made on the enhancement pattern. And the key here is the criteria, the strict criteria, because there is an overlap between malignant and benign lesion. Julio, I think it would be good if I could still see Gladys, because I cannot see if she's, if I'm going too fast.
You can move the. I don't know where you have the face of the people.
Oh, I could see her, but I've lost her. Let me see.
I can see her.
You can see her. Okay. Oh yeah, now I see her again. Okay.
Yeah.
It moved. Okay, perfect. I just want to make sure she's still alive.
Yeah, she's suffering, but she's.
Yeah, I'm sure she is.
Great.
Okay, so the strict criteria, if we are going to call something benign, it has to be 100% sure. And so that means we have to apply the criteria by the book. Example, this patient has colorectal carcinoma, and this is a staging study, the non-contrast, the portal, and the delayed. And the question I'm asking you is, what would you say? Is this something that is benign, or is it something that is malignant?
I would suppose it's malignant because it's
you're good.
dense, yes.
So why would you say malignant?
Because it's done enhanced in the contrast phase, so I suppose it's metastasis. That is a hypodensity lesion.
Yeah, but a hemangioma could be hypodense also on the portal phase. It all depends on the timing.
Yeah, it's not easy.
No, that's why I'm showing it. Okay, so the answer, we called it hemangioma, but of course, we always cover ourselves, so we say could be a MET. I would be like you. I would have said it is most likely a MET. Could it be a hemangioma? Possible, but kind of low on the list. And yes, metastases generally are hypo on the portal, and they tend to enhance peripherally and get smaller on the delayed. This was a small metastasis. What about this one? The same clinical situation, small hypo, attenuating nodule, and this is the portal, but we don't see, and we did not see it on the delayed. I don't have the delayed, but we don't see it on the delayed. So benign or malignant?
Too small to characterize. That's the
Yes.
way to get out of that problem. Yeah.
Yes, that's the way to finish the report.
Yeah.
You're right. Okay. Keep losing Gladys. I got her back. So yes, the only thing here, you have little nodules right here inside this hypoattenuating area. So you could say maybe it's hemangioma, but I agree with you, you cannot say for sure. It could be either a MET or hemangioma. With that and no calcification here, I would favor hemangioma, but I would not call it for sure. And this is the same patient, but another day, and you can see that we have the typical pattern of nodular enhancement centrally, which increases over time.
So that was an hemangioma.
So this one was a hemangioma. The other one was a MET.
Okay. The first one was a MET, right?
Yeah, this one was a MET.
And this one?
This one is a hemangioma that is proven by imaging. You don't need to biopsy. What about this one? The same story, they are all metastatic, I mean, patient with colon carcinoma. What about this thing, portal phase? So what would you do if you had this patient, you look at the portal phase and you see that, what would be the next thing you could do?
I would see a delay phase,
Mm-hmm.
minutes, as you said, to see if the lesion, and also I will see the arterial.
Yeah, arterial is not very often that helpful in those tumors. It might help if it's a hemangioma, but otherwise, but there is something you didn't mention.
You know, we do a lot of ultrasound. I actually take the patient to ultrasound every time I have
yeah, but we are talking about CT, so I agree with you. With CT, you can look at the pre.
Ah, okay, the pre. Oh.
And there is a calcification exactly in the same location. So this patient has the same little nodule that we saw on the one before, but this time there's a calcification.
Okay, so it's an hemangioma.
What?
An hemangioma, right?
No.
No.
It's a MET. If there are calcification, it's going to be a MET.
Wow. Okay.
Because this tumor often have small calcification, not often, but yeah, I mean, if there are calcification in the liver in somebody who has colon C, you have to think it could be a MET. And quite often it's a MET. At least in our population, we don't have many granulomas. Okay, and then finally, another one that looks like a hemangioma, but is not a hemangioma. And this is an example of neuroendocrine tumor. And the metastasis of neuroendocrine tumor can be many, they can have all patterns possible, but they can be vascular and mimic hemangiomas. So we call this hemangioma, we said it was a hemangioma. But at this follow-up, it was growing. So it was a MET. So that slide I have to make the point that to call hemangioma, we have to be careful also of the clinical setting. If we are dealing with a patient who has metastasis that can be vascular, we have to be very careful and even more careful. So for hemangiomas, typical presentation. It's easy to call it. Atypical presentation, we can be in trouble. They can look like malignant tumor. Sclerosed hemangioma can look like cholangiocarcinoma. These two papers are very good review of atypical presentation. The cyst, I'm going to go a little bit faster on the cyst. The cyst is the problem is usually technique. So here, solid or cystic, it looks solid to me, but it's a bad technique. How can I be sure it's a cyst besides ultrasound? So it's not a cyst, it's solid. The patient with melanoma. So for cyst, we can use the pre, and then we can use the delayed, because the cyst on multiphasic doesn't change. So if you have only a portal phase and a delayed phase, you can also use it. There will be a differential diagnosis, of course. If you have tumor that can give cystic metastasis, or if you have mucinous tumor, you may not be able to use that. But on the whole, this is helpful. Some tumor can look cystic, so we know that simple cyst may be neoplastic, like with neuroendocrine tumor or post-treatment. So again, a solid lesion can look cystic. We can use the free, the delayed, and of course, other modalities. So those are the way to. And the problem with the cyst, again, is really the technique. If the technique is good, we don't have any issues. It's only when the images are very grainy that it comes into question. So of the benign tumor that I'm going to finish with, it's a group that I find very unpleasant and complicated, that I don't like at all. It's those that are hypervascular. So the FNH adenoma group. And I think it's difficult because they are not that common, particularly adenomas. So it's difficult to really be very confident. So like with hemangioma and cysts, if it looks typical, this is a typical FNH, I'm not going to describe that, then we call it, no problems, easy. This other example, the patient has several lesions, segment 2, segment 3, sorry, segment 2, and then the large one at the bottom of segment 2 and 3. And this is the arterial phase. Portal. And here I have put a slide of the delayed images. So 2 and 3, we don't see them on the delayed. And then this larger one, we see it. What do you think?
If we have a lesion that enhances in the arterial phase and wash out, we think in ACC.
Yeah, so that's true. And that was the case in this patient, but FNH can also wash out. And that's the difficulty. So in this case, this was the result. FNH and HCC.
Can you put
And
it
this-
again to see the lesion 2? Can you put again the 2 images of the lesion 2 and the lesion in segment 2 and segment 3?
The video?
Yes.
Yeah. So here you have 2 and 3. And there is another one in 4 also, if you see right here. And then the bigger one. So I think it's really difficult because it's a diffuse homogeneous enhancement of a big tumor. And the patient has other lesions that behave similarly on the portal and on the early phase. And on the portal, you can see that these 2 are visible. There is a little scar in one of them. And then here it becomes to be hypo, right? Which is even more obvious here. But the problem is FNH can do that also. So this one was diagnosed by pathology.
Okay.
So again, if it's typical, we can call it. If it's not typical, then we have the problem that there is a risk of confusing FNH with tumor that might require resection, like some of the adenoma and HCC, obviously, or metastasis. There is an improvement with MR. MR is really, when we have trouble characterizing on CT, we go to MR, and MR is very helpful. But it's not 100%, of course. So the adenoma are difficult because they are very heterogeneous. This is a group of, this is the classification from 2006. And today the classification has 8 different types of tumors, but basically the 4 that we know something about are these. So for us radiologists, there is a problem that is not solved. Is how do we make the diagnosis of those groups? The first group, the HNF alpha, is a group that contains fat, intracellular fat, not all the time. And when we can prove that, then we know we are dealing with an adenoma, and we know we are dealing with an adenoma that is not exposing the patient to many risks. There is little risk of bleed and little risk of malignancy.
I have
so if the tumor, yeah.
The ACC, some ACC has also intracellular fat. Can you differentiate it from the adenoma?
No, you may not be able to differentiate, but it's very rare. And in general, I would say, at least for what I have seen, those tumors are, there is a lot of fat. With HCC, the fat is often very subtle, right? You might have a small area of fat. It's not diffuse, not the whole tumor. So I think the pattern is different, right? So if we have this pattern, and if the tumor is less than 5 centimeters, and this is someone who is on contraceptive, for example, then it is possible just to follow. But the adenomas that have a mutation of what is the beta-catenin mutated type, because this classification is based on the molecular biology and the genetic. And what has been shown is the ones that have this mutation are at high risk of malignancy, so they have to be resected. And there is there is a little bit progress to help us recognize, and as we thought we had made big progress to recognize this lesion, and actually there's a recent paper that is really not proving that. Let me show you. So this is an example of an adenoma, and an adenoma that contains fat. So it's hypoattenuating, a little bit of enhancement on the early phase, and then the MR just, you know, the in and out of phase proof that this is a tumor that contains fat. So here it's easy, we are done. But with this one, it's more difficult. So what has been said until recently is that we can recognize this beta-catenin mutated. We can differentiate them from FNH on using the hepatobiliary phase of EOVs, because adenoma normally, if you go back to the comparison, no, it's after that, sorry. Yeah, adenoma do not have any bile duct. FNH has bile duct. So the idea, and the papers have suggested that if we have a problem differentiated FNH from adenoma, we can use EOVist because there is a lot of uptake in those lesions because they have bile ducts, right? So there is expression of the contrast in the cell, it's captured in the cell. But the adenoma group does not have it. Only a few of these tumors are going to be, there will be contrast on the EOVist, delayed images. There's no retention. So we've worked with that, but there is a meta-analysis that was just published, this one, which looked at multiple papers, recent and older, showing that actually the beta-catenin mutated adenoma, in 60% of the cases, they do look, they retain the contrast. They are iso or hyper on the delayed EOVs. So basically, they behave like FNH. So the one that we can recognize are this one, but we cannot recognize this one. So all of that just to say there is a lot of overlap. This adenoma FNH story is really complicated. But to put back into the frame of what I'm trying to do, what I'm showing you is that we have to be very careful when we make a diagnosis of benign disease without pathology, right? Based on the imaging appearance. And here, this is of course more complex and we don't have the answer, but in general, we have to be very careful. So again, the difference between, so if we cannot use EOVs, then we can go back to the anatomy and look if we find the typical appearance between the two lesions, look at the anatomy if the MR and the EOVs doesn't work. But you know, it's not going to work all the time, far from that, and might have to go and resect or biopsy. So in conclusion, the diagnosis of benign tumor, we can do it, but we have to have strict criteria, and we need to pay attention to the clinical context. Okay, I am at half of what I'm going to talk, so I'm going to go to the malignant, and you tell me when you get tired of me, because
Cuando estén cansados de mí,
I'm trying to go slow.
de ver ir muy.
So for the benign, is there any question? Is it clear that if you look at benign, you have to be sure of what you are saying, and you have to have strict criteria because of this overlap between benign and malignant?
Yes, I think it's clear. I have a question. The the ring that is said can appear in the adenomas is how frequent is
So
it?
that's on MR. That's on MRI, right?
No, and also in CT sometimes you can see like a ring in the periphery.
So you mean a ring of hypoattenuation? The center is bright. And yes, I've seen that. And it's a pattern that I'm interested in, but I don't know what it means. I've seen it in adenoma. I've seen it in benign and malignant lesion. Not all the time. It's not that common, but yes, I've seen it. I don't know if there is something written about that. On the number of adenomas I have seen, which may be like 12 or 15 in my life, I've had, I think, 2 or 3 that have this pattern. Okay, so we move to malignant. The malignant tumor can be differentiated or classified into 2 groups. The first group, adenocarcinoma. I mean, the first one group is adenocarcinoma. And the other group is hepatoma. We can make the difference between the 2 by the enhancement pattern. We can use the morphology also, the background liver, the extrahepatic finding, the clinical context, but the most important is the enhancement pattern. The enhancement varies, is defined by intensity, how many vessels there are, and the spatial distribution. Where does the contrast go? At the periphery, centrally, nodular, etc. But what is most important is the evolution over time of the degree of enhancement and the spatial distribution. So that's the key. And this is why we do a multiphasic study. We have to see the entire movie, not just one frame. This is the story that we can make with the 4 phases that we have that allows us to classify the tumor in one another group. And why is that? Well, the reason is that the contrast material is inside the arteries immediately after the administration. Within a minute, half of the contrast is outside the vessel. And within 5 minutes, 80% is outside. So the contrast that we will see outside the vessel in the interstitial space will be collected, will be located where there is a lot of interstitial space. So the first example here. So all the cases I'm going to show you now are going to be in that order: the pre, the arterial, the portal, and the delayed. So what is the diagnosis here?
Pueden hablar los otros colegas, pueden abrir su micrófono, quieren opinar. I'm invited to the other doctor.
I know, I know. But that's okay. You can play the game.
Tenemos excelentes radiólogos aquí en la audiencia que también pueden opinar.
Well, they are not courageous, so go ahead.
Okay, so a big lesion that is enhanced a lot in the arterial phase with a scar. I first say that is a hyperplasia nodular focal hyperplasia. And another lesion that can give a scar is a femorolamellar ACC. That's
okay. So I don't know if it's a scar. Sorry, I don't know if it's a scar, but it's possible. It doesn't enhance on the delayed images, right? So I don't know if it's fluid or if it's a scar. But let's say there is not a scar. So you said another lesion could be fibrolamellar. If there is no scar, what would you call this one?
Okay, I will call it ACC.
Yeah.
Huge lesion first.
Yes, yes. So it's hypo, it's hyper, and it washes out HCC. And it's well marginated, it's a clean lesion. So what we see here, if we look at the temporal evolution of the contrast of the difference in attenuation between tumor and background, you can see that this is coming up, there is a peak, it's hyper, and then it goes down, it's hypo. Oops. What about this one?
We say there is an adenoma because of the rim that I say. They told me.
Yeah, that's an example. But the rim that you talk about, I think we see it on the portal phase. This one is only on the delayed, but it's the same pattern. I agree. I've seen that.
Okay. Okay.
So what about here compared to the other one?
That could be a scar, could be a HNF, hyperplasia nodular focal. An option.
Okay, remember, Julio, my talk is now, I've moved to malignant lesion.
Yes.
So malignant.
So I will say that fibrolamellar could be.
Yeah.
And also HCC could be. but doesn't wash
Okay.
out.
Yes. So no washout.
No.
So if it's HCC, it's not a typical one. And I'm giving you a lecture with typical cases. So the reason I'm showing these two cases together is because they are very, very different if we look only at the enhancement, right? Bright, dark. Bright, bright, bright.
Yeah, it could be a metastasis of a hypervascular tumor also.
Yes, so the only thing, the reason you have difficulty is because this is enhancing a lot on the arterial phase. And metastases, we expect them to be hypo, right? But that here, the enhancement centrally and the peripheral hypo on the delayed phase is typical of an adenocarcinoma of the contrast that has migrated toward the central portion of the tumor. So what you see in those two cases is, in the first example, no interstitial space, a lot of interstitial space, right? Because we have all this contrast that is there. And what it means in the tumor, that means there is a lot of fibrosis. No fibrosis, a lot of fibrosis. So this type of tumor, I'm going to talk now about the group that I put under hepatoma. So the tumor that have this pattern, they are usually enhancing more than the background. But the most important thing is here, there is no delayed accumulation of contrast, no washout, no accumulation of contrast and evidence of washout. So what about this one?
In a cirrhotic liver, I will first think in HCC with a.
Yeah, so we have the same, yeah, this is bright, and it washes out. Same curve, covering arterial and portal phase. What about this one? So it's easy. I mean, it's easy. I've seen those cases 500 times, so it's easy for me. But what is easy is...
It could be HCC. It could be HCC, but not sure.
No, you are not sure, but you could be almost sure because the pattern is the same. Bright, washes out. And here you have a rim of increased attenuation, which is a capsule. So your first diagnosis is not going to be 100%, but your first diagnosis is going to be HCC. Could it be a MET? Yeah, it could be a MET. But it is a typical pattern of HCC, so that's the common thing. That's the first thing you say. Peak, washout. Same thing here. Just try to recognize the movie, right? Hypo, a little bit hyper, very hyper, washout. So again, we have the same up and down. And on the delay, there is never an increase in the contrast in the tumor. And this is the same here. It is bright, it's become ISO, and it's hypo. So with something like that, could it be a MET? Yes, it could be a MET, but it is washing out. It is hypervascular. It's HCC until we have the proof that it is not. Does it make sense?
Yes, yes. I didn't, the case of the interstitial contrast in the ACC was very good, and I haven't seen much cases like that.
Yeah, the HCC does not enhance on the delayed because this is not a fibrotic tumor. That's the difference with the adenocarcinoma, the cholangio.
Oh, the other one was a cholangio.
The one that had a lot of contrast on the delayed is a cholangio. Yeah.
Ah, okay, okay.
See, I was showing you the two big types. The type number 1 here, HCC, which I've just showed you more cases. And the type I'm going to talk now about is the adeno, which is this group, to show you that there is a big difference between the delayed phase. That's the delayed phase is what makes the difference between the two tumors. So what about this one? This stuff. So this one is a clean tumor, which enhances a little bit. And here it looks like, you know, is it washing out? I think it is. But again, it is very clean, very sharp. It's hypo to the background. There is no accumulation of contrast on the delayed images, and that's the key. So it's an HCC. There's another example of an HCC, which is not very vascular, but on the delayed, you can see this is very hypo compared to the background. There is no accumulation of contrast on the delayed images.
Okay. This
one is even more complicated because there's no enhancement whatsoever. But then the key here, and again, I'm not saying you can make the diagnosis of HCC for sure, but the likelihood that this represents an adenocarcinoma is low. It's not excluded, but it's low.
For adenocarcinoma, we expect to enhance in the delay phase, right?
Yeah.
That's the main
it's not always the case, but what I'm trying to show you is that about 60 to 70% of the time you can follow this pattern and you are going to be correct. But of course, there will be cases that don't behave the right way. And then we need to work more. But if you use that as a frame, as a first approach, then you have already classified most of the disease. Not all, but most.
So it's better to see the density in the arterial, and we can say that it's lower in the delay. It could be HCC hypotension.
What you can say, if you may not be able to say it's lower, visually, you may not be able to say it's lower. When you measure Hansfield unit,
it's the same, but the liver.
When you measure, sometimes you can see that it is lower, even though your eye doesn't show that.
Oh, okay.
So those are the curves of those tumors I showed you. The first group is this group. So this is the relative tumor attenuation compared to the background. This is isodense. So this is the background, hyper, hypo. And the first group, all the tumor became hyper, right? At some point. Sometimes in the arterial phase, sometimes in the portal phase, sometimes in both, but the overall movie is the same. The second group I showed you were hypo. So they were tumors that did not enhance above the background. They were iso or hypo. And what matters is that in both groups, there is no increased attenuation over time. It's stable or delayed or below, lower. So that's for the hepatoma group. And if you do Hansfield unit measurement, that's what you see. You get a peak and then a decrease. And this is an example of a neuroendocrine tumor, and this tumor behaves like an HCC. It's hyper and then it's hypo. Okay, so now I'm moving to the second group, the one that enhances on delayed images, which sometimes can be hyper, most of the time is hypo, but is characterized by an increased attenuation on the delayed images. So this one is an example of a tumor that is enhancing a little bit on the arterial and portal, but look on the delayed. So this is typical of a fibrotic tumor, which means it's either a cholangiocarcinoma or a metastasis, especially from colon. What about this one? So try to apply what I just showed you. What is the movie here?
Yeah, the movie is that it enhance slow and then wash out, but enhance the most in the portal phase. So yeah, it could be a metastasis.
Yeah, so you cannot say it washes out, right? It is still above the liver. The attenuation here is still higher than the liver. And the degree of contrast here, I think, is increased a little, maybe not. Yeah, I should not say that. But anyway, the point here is that it is not washing out because it is still above the background.
But have the
So,
peak in the portal.
So it's different from that, right?
Yes.
This tumor is enhancing also, but look at the delayed. It's very different. So the one I'm showing you now, the delayed is very different. It's not clean. It's not hypo. It's still with a lot of contrast inside. So it's a fibrotic tumor and it's not washing out. And you're right. This actually, it was a cholangiocarcinoma, but it's the same. You understand the difference?
Yes, I get it.
So this is another example where there are multiple metastases. They enhance a little bit on the early phase. They are hypo, and then look on the delayed, they fill in. So the same principle, right? These are metastases with a lot of fibrosis, and they become hyper or iso on the delayed images. And this one is the same. You lose completely the tumor, like on the breast CA patient I showed you earlier. The enhancement is more important here, but then as time goes, it just increases and the tumor disappears because there is fibrosis and because the contrast material is outside the vessel. So those are the same curve as for the other situation. Here, only a few tumors become hyper over the background. They are usually hypo or iso. On the delayed, the contrast increases or the contrast remain, but we don't lose the contrast on the delayed images. And then when you do attenuation measurement, you get an increased contrast over time, but here we don't have that peak, that slope that goes down as we had with the HCC. We have tumor that keep the contrast. So is it clear? And do you get it? What I'm trying to show?
Yes. Sí, creo que vamos quedando claros, ¿verdad, muchachos? Pueden opinar para no solo hablar yo, voy a aburrir.
Okay, do you want, I have maybe another 10, 15 minutes. Do you want me to keep going or you want to stop?
No, you can keep going.
You're courageous.
Sí.
Maybe we should ask Gladys if she still wants to do it.
Sí, Gladys es la que está haciendo el trabajo más duro de todos. Sí,
Okay, so the second group I just talked about, the fibrotic, the cholangiocarcinoma or the adenocarcinoma. Most of the time they are hypodense, but they can be iso, like with the breast I showed you, or with some of those cholangio I showed you. The key is this. The accumulation of contrast with an increased attenuation on the late phase. That's the key. So really, if you go to the delayed images, that's where the money is. That's where you get the information. So too small to characterize. I showed you a couple already. You can use that movie scene to characterize tiny lesion if the technique is good. So this one is a pretty nice study. This is a bright ring of enhancement. The history is HCC. So if you see that, you're going to say, oh, this is probably recurrence. And you look at the delayed or the portal phase, it's later, and you can see this is becoming hypo.
Yes, that could be ACC.
Yeah, so you are pretty safe to say this is HCC. And this one is also too small to characterize in this tiny thing in segment 8. So what would you do if you wanted to characterize? Not an ultrasound.
I will see the non-contrast phase.
Yeah, I'm giving you the non and the delayed. So on the non-contrast, like the other case, you see there is this relatively large hypoattenuating nodule. Bigger than that, so we know this has been enhancing. And then you have the delay that shows retention of the contrast. So this is consistent with the MET. Could it be a hemangioma? Possible, but not very likely. Okay, this is a quiz. This is complicated. So look at the bottom part of the screen first and decide based on the movie theory what tumor it is. And then look at the top portion and with the same principle, tell me what tumor it is.
Okay, let us think a little bit. Y pueden opinar, muchachos, si gustan, ¿verdad?
Looks like you're the only one here. You and Gladys and me.
The Braves. Okay, so we have lesions that see in the non-contrast enhance hypodense, then enhance a lot in the arterial phase. And then at the delay, some have some contrast, and someone maybe wash out and some, but not much.
Yeah. So what do you do with that? You have the two pattern on the same patient.
Yes. So, and we have with several lesions, I can say that maybe in we have ascites, I don't remember how to say in English.
Yeah, this is ascites.
So this is the left lobe is bigger, so maybe cirrhotics. So maybe the left side maybe look like metastasis and the right look like ACC in the
yes. Okay, so yes, you did good. You passed.
You passed. Oh, all right.
Yes. Actually, it's good for me because that's the proof you have been able to follow.
No,
so here you have hyper, iso, hypo. That would be HCC, right? Or at least a tumor that belongs to the group of HCC. And here you have a tumor that keeps the contrast on the late phase. So if we read that, we are going to say that there are two patterns of enhancement compatible, one with HCC, the other one with cholangio. And what about this tumor?
So we have the first two are the arterial at different levels, and the two more are the portal and the delay.
Yeah, I think it's the same level. It's just that it's an old case, and we used to have very early arterial phase, like 30-second delay. We don't do that anymore. So take this one as the arterial, and then this as
So we have a lesion that in part of the lesion enhanced in the arterial, and then is one part washed out and the other part enhanced.
Yeah.
So
right. So this one is enhancing over time, and this one is losing contrast. So it's a tumor that by pathology is a mixture of HCC and cholangiocarcinoma.
okay. The adenoma part that looks darker, we can say that could be some fat in the tumor or not. That's
no, I don't think so, because it enhances. You see, if it was fat, this would be still black on the layer, right? I think it's just the window. It's because the window, and then here you can see it is not as dark. I think it's just the windowing, because I narrowed the window to see the enhancement. Okay, well, you got it. So now the bad news is that it works 60%, 70% of the time, but not 100%. And there are a lot of papers fairly in the last several years showing that the size of the tumor varies, that you have a variation with the differentiation. So well-differentiated tumor, for example, for HCC, wash out only half of the time. So it's, you know, it's not always working. And then the same thing with the cholangio, there is a relationship between the differentiation and the enhancement pattern. So those are papers that are talking about that, which I think are helpful to read. And this is an example here. This patient has this small nodule, which is hyper, and stay hyper, right? So if I apply the movie story, I'm going to say, well, it looks like it's not washing out, so I'm going to go for an adeno. But the pathology was a moderately differentiated hepatocellular carcinoma. And this is another example where I cannot make the diagnosis. It enhances more on the delayed, and contrast is stuck in this tumor. I don't know what it is. And it was a poorly differentiated HCC.
I have a question. What has more specificity? If we have a lesion more than 2 centimeters in a cirrhotic liver, or the pattern, vascular pattern?
I think that the size is going to guide you towards saying you need to biopsy, right? Because you are dealing with a cirrhotic liver, and above 2 centimeters, you have to be worried of cancer, whatever the pattern, right? So it depends on the clinical context. If you are screening liver, cirrhotic liver, and you have a nodule that is large, you're going to biopsy.
Okay. I have another
question. I don't have...
I have another question. In MD Anderson, they are biopsying all the tumors or all the HCC because of the molecular information that can have right now, or they are just doing like the criteria that doesn't biopsy the.
Yeah, no, we don't. I don't have an answer, strict, clear answer for that, but we don't biopsy everybody. If this is a typical pattern, this is a typical pattern. But if the patient is on a protocol that calls for molecular studies, they would do it, but that's not the routine. If we can make the diagnosis, that's it. They treat based on the imaging.
Okay.
Okay, and then on this case, if I do the movie thing, I'm going to say, okay, there is a little bit of enhancement, it's hypo, but look on the delayed, it's really very hypo, and then there is a portal thrombus. And I would say, you know, I would consider HCC. Now, against HCC is that it's ill-defined, it doesn't have sharp margins. But the pattern of enhancement is not typical for an adeno, and this was a poorly differentiated adeno. So, you know, I mean, I think what I showed you is what I've used almost my entire career to look at hepatic tumors. And it works a lot. It helps you organize your thoughts. But obviously, as I'm showing you here, there are cases where you are not going to be able to make the diagnosis. There's going to be a biopsy. And also, I haven't really, we use more than imaging, more than the enhancement pattern. We use the clinical context, the history, the other findings, right? We put everything together. but the enhancement pattern is one of the really big factor in making the diagnosis. So to conclude, which technique to use, you use what you have and what you are good at. If you have everything, the clinical question, in my opinion, is what should guide the choice. And the diagnostic value of any technique will depend on the quality of the images. And the attention of the radiologist. So we looked at detection and characterization. With the detection, what matters most is the technique. The characterization, the enhancement pattern is the most important part. I did not talk about that, the older scan. But obviously, that's also super, super important if there are images for comparison. We can say some tumors are benign for sure, but we have to be very strict. And for those that we deem to be malignant, we can go further and categorizing them in one of two groups. And as I showed you, the delayed images are really very, very important because of the relationship between the distribution of the contrast and the fibrotic nature of the disease, the presence or lack of fibrosis. So that's it. Thank you.